Hello and welcome to another episode of the Euro-Onco platform. We are in Budapest. We are attending the Euro-Onco 24 event, and it's our great pleasure to have here today with us Dr. Elena Castro, who is a medical oncologist based in Madrid, Spain, and she's one of the top experts in the field of prostate cancer, advanced prostate cancer, and other GU malignancy. So welcome, Elena.
Thank you. You are very kind with this very nice introduction.
And so we discussed during this meeting in many sessions about the toxicity and quality of life of the treatment we now currently have available for patients with advanced disease. So one frequent and recurrent topic is we are now living the era of treatment intensification. So we have a proof of the improved oncological outcomes, but would it be possible in select patients to stop or suspend at least for some time this treatment, mainly in those who are good responders, so that we can spare the toxic side effects of hormone treatment?
Yes, absolutely, particularly for patients with metastatic hormone-sensitive disease, in which we should add an androgen receptor PARP inhibitor, an ARPI, to ADT, because it has demonstrated to improve the outcomes and overall survival of these patients. But I think we all agree that there are patients that even when they may benefit from this intensified treatment, they are very good responders, and perhaps they can also benefit from stopping treatment at some point, perhaps having an intermittent treatment, or perhaps we are able to identify those who can get treatment for a period of time and then we can safely stop that. The trials are ongoing. We need to wait and see the results, and these trials are particularly focused on those patients who achieve very good PSA responses in the first 6-9 months, as it suggests these may be very sensitive, very hormone-sensitive tumors that can be managed this way. And I agree with you, sparing toxicity for these patients is key.
So, Elena, you have a very large experience in the real-world setting with the administration of these drugs. So, can you please guide us through the most common side effects of these different drugs that are increasing every day in our armamentarium?
Right, I think the audience is very familiar with the side effects of the androgen receptor pathway inhibitor, which is mostly cardiovascular events, particularly hypertension. Some patients may experiment fatigue, or falls have also been associated with some AR inhibitors, alterations in the lipid profile or the transaminases. But in general, these therapies are very well tolerated. We also have chemotherapy. It has been around for many years. The most frequent side effects are cytopenias, anemia, neutropenia. Neutropenia is more frequent with cabazitaxel than it is with docetaxel. We know how to manage these patients. We know how to prevent it with granulocyte colony stimulating factors. And fatigue is also an issue with this chemotherapy. We are good at preventing nausea and gastrointestinal side effects. That is a big concern to our patients, but in real practice, we really know how to deal with that. And hair loss is also a concern for our patients, and unfortunately with docetaxel is something that we see quite frequently. Nail changes as well, and neuropathy can be frequently observed with docetaxel. Now we also have other cytotoxic therapies, as is the case of PARP inhibitors. PARP inhibitors are associated with more anemia and thrombocytopenia than chemotherapy. Grade 3 anemia can be frequent depending on the PARP inhibitor, but with some it could be up to 50% of patients that present grade 3 anemia. Grade 3 anemia means the patient may require a blood transfusion, but we can deal with that. So I think we need to be aware of the toxicities, but we can manage that. Thrombocytopenia is also more frequent. We can see that in around 15% of patients, with some PARP inhibitors more than with others. Gastrointestinal toxicity, particularly decreased appetite and perhaps nausea, not so much vomits. And fatigue. Fatigue is also frequent with PARP inhibitors. And we have radioligands as well. Radium-223 has been around for some years already, and now we have more and more access to lutetium, PSMA. Radium-223 is associated, of course, with some cytopenias, but not as frequent as with the chemotherapy or PARP inhibitors. And in general, it is well tolerated. Some patients may also complain of diarrhea. With lutetium PSMA, there may be some fatigue, but also serostomia, because it also affects the salivary glands. And we need to be vigilant of the hematotoxicity, but in general is well tolerated. There may be some kidney may affect the kidney function in some patients, and we need to be vigilant as well. But in general, these drugs are very well tolerated.
Yeah. Great, thanks. And so the next question is, of course, who should manage this toxicity? Because these patients can be seen even by the urologist. They can probably come back to the initial urologist or to radiation oncology if they receive radiation therapy during their course, or to the medical oncologist. So do you think we should set up a kind of task force or a multidisciplinary team even to manage these toxicities that may affect various organs and various functions? So what is your take?
Yes, I think we need to be aware that these toxicities may happen, and we have to have a plan to deal with that. So often the way to manage that is that the person that prescribes that take care of the or the department that prescribes take care of the toxicities as well. But if that is not possible, or it has been organized differently, that is okay, as long as we realize this can happen and someone is going to take care of these toxicities. In some hospital is the internal medicine department that takes care of these patients, or is the oncology department. It depends on how things are organized, but I think it's very important, the communication among specialists to provide the best care to our patients.
Thank you very much. So thank you, Elena. I think you provide us a great overview. And so the quality of life issues are very, very important in this patient, because many of them can have very long trajectory. And so thank you again, and thank you, listeners, and stay tuned for the next episode.